Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. We have a wonderful guest here tonight. All my guests are wonderful, so I can't say enough for them. We're going to talk about kidney disease, and we have an expert who's a kidney or renal specialist, nephrologist is the word, Dr. Solomon Dalezman. He works at Richmond University Medical Center, and it's a pleasure working with him there.
It's a pleasure to be here.
I see him on rounds all the time, and thank you so much for coming.
It's a pleasure to be here. Thank you for having me.
So let's talk about kidney disease and really who takes care of it. So you're a nephrologist.
Correct.
And tell us how you got to be a nephrologist.
Yeah, so after medical school, 4 years of medical school, then the first step was specializing in internal medicine, 3 years of internal medicine, which is the training required to be a general internist or general doctor. Then after that, I took 2 years to specialize just focusing on the kidneys and different diseases related to the kidneys, which is nephrology.
Oh, that's marvelous. So when we think about our viewers, people talk about their kidneys a lot and in different ways. When do people refer to a kidney specialist?
So most of the time, it's something that's picked up on routine blood work. When you go for your annual physical, your doctor is typically ordering blood tests, and as part of routine, regular blood work, one of the things they look at is creatinine, which is what we use to measure kidney function. That, along with some other tests, urine tests in particular, are very important. If there's any blood in the urine, even if it's invisible to microscopic, that can't be seen by the patient, that'll be picked up on tests. So those are typically the things that'll prompt referral to a nephrologist, either abnormalities in the blood work or earlier some changes in the urine, blood protein in the urine.
So there are different things that you find, and based on an abnormality on one of these screening tests, then you'll go through your workup and get other blood work. You get imaging pictures of the kidney, see what things are in order to try to come up with some ideas.
Exactly right.
So I know that nephrologists deal with a lot of the more difficult to treat high blood pressure patients. Most of the internists, primary care physicians will treat blood pressure, sure. But a lot of times there'll be an issue. And it's for many people are comfortable saying, well, my cardiologist helps me with blood pressure medicines. And in my training, it's always been the nephrologist or the kidney doctor who really have taken on the most difficult cases because of fluid management, and sure. That's really what the kidney does. So tell me a little bit about blood pressure. Yeah,
so the kidneys, as you said, many people assume that the heart regulates blood pressure. It does to an extent, but definitely by the main job of regulating the body's blood pressure is the kidneys. It does by a couple of mechanisms. The most obvious one is the kidney is responsible for regulating water. Urine, which is produced by the kidney, is obviously largely water. Salt as well, and regulation of the salt and water, that's what maintains pressure. Pressure is the flow of fluids through a body, through an object, in this case the body. So regulating how much fluid there is, how much salt there is what will control the blood pressure. Along with that, the kidney, aside from the obvious fluid control, perhaps the more important aspect is the kidney has a bunch of sensors which actually sense the pressure in the body. And it releases various hormones and then a whole complicated cascade that has effects throughout the entire body. These hormones can constrict, meaning to tighten blood vessels, which will raise the blood pressure, loosen blood vessels, which will lower the blood pressure. This is the kind of regulation is all coming from the kidneys. So as a nephrologist...
So people with difficult to treat high blood pressure, you guys really have a lot of ideas about the hormones, the mechanisms, the fluid management, because I think a lot of us in the medical world, and again, not as much as a neurologist myself, really some medicines that we have, and maybe go over a little bit of what they do. I know there are diuretics, there are medicines that affect fluid, so maybe just give us a little idea of of some of the medicines that are available for high blood pressure that people might be taking and as to why it might work.
Sure. So there's many different classes of medications, and within each class, they're somewhat interchangeable. You mentioned diuretics. Hydrochlorothiazide is a diuretic, often one of the first options chosen to treat blood pressure. So that works primarily on a specific part of the kidney by regulating salt and fluid to help relieve pressure by driving off some more fluid. There are other diuretics, loop diuretics, Lasix being a common one. or furosemide, which can often be taken together. They work in different parts of the kidneys, they can be added. Then there are a whole bunch of other medications that work on different parts of the body, ACE inhibitors and angiotensin receptor blockers, or ARBs for short. Are both two classes of medication that, practically speaking, function somewhat similarly. They both work by vasoconstricting, meaning they tighten the blood vessels that feed into the kidney to help regulate the pressure. Because again, it's the kidney that's sensing that high blood pressure. So by lowering the amount of blood going to the kidney, it doesn't sense that blood pressure as high. So it kind of tells the kidney to calm down. The pressure is okay. Don't get so excited. Then there are other medications that have effect throughout the body by relaxing blood vessels, things like calcium channel blockers. That's a whole bunch.
There are tens of millions of people
Yeah.
with high blood pressure. And anyone who's taking a medicine for high blood pressure sort of wants to think that their medicine is the best medicine that could be out there and the right medicine for them.
Right.
Is there a logic into what medicines are used first, second, third line? And really, should people, when your internist gives you a medicine, I believe very much in knowledge is power.
Sure.
So we have people watching us today who maybe in the last month or two will be put on a blood pressure medicine. Even before we get to the medications, do you believe that blood pressure can be regulated by salt intake and diet? Because so many of our patients say, give me a chance. Let's see if there's a way that we can take my blood pressure down.
It's hard to give a straight answer. The short answer is yes, but within reason, meaning if it's a small amount. A normal blood pressure is, say, less than 130. So if the blood pressure is 170, changes in diet aren't going to cut it. But if it's 135, in that range, it's reasonable to give an attempt of reducing salt intake, exercising more, stopping smoking if the patient's a smoker, things like that certainly are reasonable. But if it's much higher, certainly if it's over 140, I would jump straight to using some sort of agent, some medication to help.
And how many of our patients will use the term white coat syndrome, where they explain away one or two readings? Do you have people taking blood pressure at home when that happens? Because again, some patients are very frightened about coming to the doctor. I mean, sometimes we have children who cry when they see their white coat. But again, so many of our patients, you see their pulse rates going up. They're very anxious. They're coming. Even to me as a neurologist, they're worried they have a brain tumor or some terrible illness. Understandably so, and their blood pressure might be high. So in a sense, when they go to, how many times could you go to your internist for your routine or annual physical exam? And if your pressure is high, you can't say it's always because it's this.
It's tricky because it's, if it's real white coat syndrome, it very well may be that, due to that, but the solution is to check it at home. And I would caution the patient to bring in their blood pressure machine, because sometimes the machines, especially the forearm machines, aren't quite as accurate as, definitely not as doing it manually, but even compared to the upper arm, tend to be more accurate. So I'll have them bring in the machine, and we'll compare to make sure it's working accurately. And I'll have them go home and check their blood pressure, maybe once a day, twice a day if the blood pressure is really high, and we'll see. If it's always high when you're not around the white coat, it's harder to blame. But if in fact at home it's controlled, I think it's reasonable to monitor.
And is there somewhat of a cookbook? And again, nothing's cookbook in medicine, of course, but which medicines to start first, second, or third? And again, even for different people. I mean, African-American populations, different issues with regard to blood pressure, women versus men.
Sure.
So how do people figure that part out? Or again, your doctor gives you the prescription, obviously. Right. But how do you know that you're on the right medicine?
Yeah, there is somewhat of a cookbook, just from, which is largely driven by data. Hydrochlorothiazide we mentioned is often the first line. But perhaps a better approach that I find is to try to kill two birds with one stone. What I mean is, if there are many medications which have multiple effects. So, for example, we were talking about ACE inhibitors earlier. So ACE inhibitors have been shown to protect the kidneys, especially in diabetics. So for a diabetic who has hypertension, which often those two go together, certainly my first line treatment for blood pressure would be an ACE inhibitor or angiotensin receptor blocker, or ARB. One of those would be my first choice, just to kind of cover two ends. If the patient has a history of heart attacks or atrial fibrillation or some a rhythm abnormality in the heart, then a beta blocker to slow down the heart even though it's not the most effective blood pressure medication and typically wouldn't be first line, in that case, it would be an appropriate first line choice because you can kind of try to manage two things with once, of course, with one agent. Of course, if you can't and you need to add something, which you often do, then you'll add. But I think that's the best approach.
So that's how we get the combinations of medicine in order to
Yeah, there are some very classic combinations that go together, and by taking one pill, you can take two medicines.
Do you feel that most patients can have their blood pressure controlled without major side effects? Because I think so many of our patients are concerned about the lightheadedness, and I've seen patients who fainted, again, maybe they took an extra pill accidentally, or even just because the medicine they're taking, they didn't eat or drink that day.
Sure.
So people are so concerned about the side effects of medications. Then we have the other group of patients who their pressures are so difficult to control, and different times. I mean, I see patients who've had a stroke. We don't want their pressure to be too low, so we allow it to rise up around the time of the stroke because we want to still perfuse the brain. But that's only for about a 1 week period, even less, 3 to 7 days. So really the question comes down to is, do you feel that most patients can be controlled?
Most can. There are tricky ones, certainly, but most I think can be controlled. There are potentially. The most I have a patient on 8 different agents. So that's I don't have many, and that patient I'm having a hard time controlling, as you can imagine. But until you get to there, there's a lot of options. So most patients can be controlled.
There's even some surgical options now, I believe, that are becoming more involved with denervating or doing things to the kidney and different techniques.
Yeah, there are some, for the very difficult patients to treat. But typically, I've already referred them out if it gets too tricky at that stage.
So let's talk about stages. A lot of my patients come in, especially if they're going to go for, as a neurologist, we use contrast for MRIs and things, and we always ask what their kidney function is, or even if somebody comes in who's had a stroke and I see them in the office
Sure.
or at the hospitals. We both have an outpatient part of our practice and an inpatient in the hospital part of our practice. So many of our patients will come in and they'll say, well, you can or you can't do this. I'm stage 3, I'm stage 4. I mean, they basically have numbers to associate
Right.
with it. And sometimes those numbers are a little bit misguided. I mean, we sort of sadly to think about stages of people with malignancies
Right.
and how bad stage 4 is. But, and again, I'm not going to equate them exactly, but stage 3 and whatever. Could you give me a little idea about when we get concerned and what the numbers mean when you're given some stage in your kidney disease?
Certainly. The role for the stages is the kidneys there's a vast chasm of renal function, meaning we'll use the test we use to estimate the kidney function is EGFR. It's measured, we were talking about creatinine earlier. Creatinine is the blood test. The computer uses the creatinine to calculate an EGFR, which stands for estimated glomerular filtration rate. It estimates how well the kidneys are filtering. For simplicity's sake, we'll say 100 is perfect and 0 is 0. It's not quite right, but it holds true. Now, a patient could fall anywhere on that giant line from 100 to 50, 10, et cetera, et cetera. So it becomes and those patients, as you can imagine, there are big differences between them, between most of them who it wouldn't even be picked up on blood tests, because the blood tests aren't quite so accurate to pick up skeletal tests. The patients who are close to dialysis and so much in between. So that's where they came up with this, the system of staging. Staging is just a way to it's somewhat arbitrary, but just to make a cutoff. So stage 1 is 90 and above, which, again, we're going to go with 90% kidney function and above, practically normal. Stage 2 is from 60 to 90. Those patients typically aren't even caught and don't even see a nephrologist. Most of them don't know they have it. Yeah, it's picked up on very subtle tests, or if they have protein in the urine. Then stage 3 goes from 60 to 30. Stage 4 is from 30 to 15, and stage 5 is from 15 down. So people do get caught up on the stages, but what matters more than the stage really is the trend. Meaning, if a patient has been, let's say, stage 4 for, 10 years, I wouldn't say that's good, but it's stable. Hopefully, they're being managed, they're seeing their nephrologist, they're taking the medications, they're controlling their blood pressure, like we were talking about, the diabetes, et cetera, and it's stable. On the other hand, a patient who they had a EGFR, a kidney function that was 100 a week ago, and now it's dropped to 60, even though they're stage 3, which you might think is better. I'd be anxious. What caused a sudden drop? So the more important part in the stages it's useful to know your stage, but you really want to know where it's been and where it's going. If it's been in that range in the past, it's fair to keep an eye on, and hopefully it stays that way.
How do we slow down kidney disease from getting worse?
It's easier said than done. The main thing really is to control the factors that lead to the kidney disease. The number one cause of kidney failure in this country is diabetes. Approximately 50% of all CKD is as a result of diabetes.
Chronic kidney disease.
Chronic kidney disease is as a result of diabetes. 25% is a result of blood pressure. So those two things, just those two conditions alone, account for approximately 75%. So if trying to prevent the onset of diabetes, being careful with, especially if there's a family history of exercise, keeping an eye on A1C, getting it checked regularly, avoiding sugary foods, sodas, et cetera, to try to prevent diabetes. And if the person does have diabetes, to stay on top of the diabetes. If they need insulin, then insulin. Whether it can be managed with pills, then the pills. But that's by far and large the main thing. And along similar lines, same thing with blood pressure. To stay on top of blood pressure and to keep it as well controlled as you can.
In my training, many years ago, the amount of protein that someone was taking in was a big deal with regard to kidney disease. People were told to cut back on the protein, and people always were confused. What could they eat? There's carbs, there's protein, there's fats. What should they do? And you always would have to get the nutrition people involved when being told that you can't have protein. So tell me about the relationship between eating protein, or how much of protein you're taking in, and kidney disease, and whether people who have minimal kidney disease cut back, or you sort of got the question.
Yeah, certainly. I tell patients not to worry so much about the protein and to worry more about the diabetes if they have, and salt if they have high blood pressure, which they usually do. I find once you start throwing too many things into the mix, then it all gets thrown away. The protein, certainly red meat, is associated with high blood pressure, and which results in kidney disease, like we're talking. But the protein intake itself, I think we've largely moved away to some extent, and isn't as much of a concern.
We have a model.
Okay.
So let's look at a kidney, because we think about a kidney bean, we think about what a kidney looks like, so we can look at it from both sides, what it looks like from the outside and from inside.
Oh boy.
And it's always nice to image, to see what's going on with it.
Yeah. So we have two kidneys. They're here on our back, and this is roughly to scale. It's about 12 centimeters or so, 5 inches. This is the way it looks from the outside. So this would be a left kidney, although when you cut it open, it turns into a right kidney. It's wearing this little hat, which is known as the adrenal gland, sitting on top of the renal gland, which secretes some hormones that play a role in blood pressure, but isn't directly involved in the kidney. And this is really where the magic happens. Here we have the renal artery. Our artery brings blood away from the heart, so it's bringing blood from the heart to the kidney. The blood perfuses the entire kidney. And there are these microscopic small functioning part of the kidney is called a nephron. Nephros is the Greek word for kidney, which is where nephrology comes from. And there are millions, there's about approximately 1 million of those nephrons in this one kidney. And they kind of all converge together and form and produce and filter the blood. So the blood goes through the renal artery, spreads throughout the entire kidney, goes into these nephrons. The clean blood gets returned to the body through the renal vein. It's not actually blue in the body, but just to show the difference, they color it blue, which is pretty common in anatomy textbooks. And the waste, the discard, goes down through here, through the ureter. The same thing's happening on the other side. The two ureters go down to the bladder, and the bladder fills up with urine constantly throughout the day, producing urine. And then when it's time the appropriate time, you go to the bathroom and empty the bladder.
So let's talk about something that frightens a lot of our patients. So let's talk about kidney stones. So you talked about the ureter, that's a passageway. How do you get a stone there? I mean, you think about everything in our body, there's not much stone-like material.
Right. So a kidney stone is essentially just a salt. A salt is a combination of two different minerals, two different elements. So, table salt, for example, is sodium chloride. We were talking about sodium before, and that's and that's what produces which is a big chunk of our body. So kidney stones form when there's an imbalance of these different minerals that allows them to form a salt. If you take salt and dissolve it in water, it'll dissolve. If if you have too much salt in the water, eventually you're going to start to see salt clumps. It's the same thing in our body. The most common form of kidney stone isn't sodium chloride, but it's calcium, either with phosphate, not so much chloride, but the calcium phosphate is one of the most common stones. So when these two elements form in the right amount, they crystallize. And when the stone's there, it actually doesn't hurt. When it moves, though, that's where the pain is. And if it gets lodged in or wedged in someplace, then it can cause significant damage.
By blocking the flow.
If it blocks the flow to the kidney, if it gets stuck down here in the ureter, then it can block the entire kidney, potentially causing kidney failure if not caught in time. But fortunately or unfortunately, patients are in such pain that it typically gets caught before that.
And there are treatments for
There are treatments, yeah. The urologists, I don't do the treatments for the stone. The urologists are surgeons that deal with kidney-related issues, so they can sometimes break it up with just with shock waves, or in such a severe case, if it's actually blocking, what they'll have to do is put a kind of a catheter through the back to drain the kidney. But typically, it doesn't get quite that severe. It's caught earlier that some shock waves can break it up, or they have other methods up there.
Are there medicines that people can take to reduce the production of these?
So that's where a nephrologist fits in. If the stone's there, it needs to be dealt with, and there isn't much that can be done medically to deal with them. But to prevent the kidney stones, there are some tests. Typically, what we'll do is we'll have the patient collect their urine for 24 hours, and we send the whole bucket of urine to the lab. And the lab does a whole bunch of tests to see how much of calcium, like we're talking phosphorus, sodium, all these different elements are in the urine, and we can intervene. Sometimes with the diet, they need to take less calcium. Sometimes, believe it or not, they need more calcium, because it's all about finding that right balance to prevent the stones from forming. There are medications that can limit the amount of calcium, hydrochlorothiazide, for example, which goes back to the previous question. That would be a patient with a history of kidney stones and blood pressure, hydrochlorothiazide, 2 birds with 1 stone. Limits the amount of calcium that goes through the urine, thereby hopefully preventing kidney stones in patients that have a specific type of calcium kidney stones.
So now we're going to go into something, of course, everything we've talked about is very serious, but people are so frightened when they think about dialysis and then possibly even kidney transplants. And we have about 5 minutes left. What advances are there with dialysis? I mean, clearly there are different kinds of dialysis. The fear of people going on it. Some people have told me, even when they've come into my office, I want everything but dialysis. I don't want to be put on that kind of a machine. And how do we make these people have normal lives whose kidneys just don't work?
Right.
And so what do you do and what do you tell people?
Yeah, so unfortunately there aren't really any advances in dialysis, but I have a caveat which we'll get to in a moment. The dialysis, what I tell patients is that it provides a solution, meaning years ago, not all that long ago, 60 years ago, there was no dialysis. That was it. Now with dialysis, patients can go on living a reasonably normal life. Patients go to work. Patients can, I've had patients get pregnant on dialysis. So while far from ideal, it's manageable. Something that is becoming more popular is to do dialysis at home. Either what's, for lack of a better word, I'll call regular hemodialysis, which is dialysis that involves cleaning the blood, can actually be done at home. Patients are taught how to do it. And there's a dedicated machine that they keep at home, and they're taught how to connect themselves. A family member has to be with them. A family member would be taught as well. And they can do it at home at night. So by day, they could be having a conversation and walking around, doing the thing. And at night, either while they sleep or a couple hours while they're watching TV, before bed, they do dialysis at home. Another option is peritoneal dialysis, which is completely different. It uses dialysis through the belly. The belly has a natural membrane called a peritoneum. So that area is filled with fluid and allowed to sit there. And on its own, the toxins that accumulate in the body kind of diffuse out into that fluid. And the patient dumps it out, and those exchanges are done a couple times a day. Again, the advantage there is the patients can do it on their own and do their, otherwise do their own thing. Some patients prefer, they want nurses involved, and so they go to a dialysis unit, and if that works for them, that works for them.
But patients can live years and do well
They
on
can.
dialysis.
The life expectancy certainly is reduced, but the best option that ultimately is to get a kidney transplant.
So tell us about kidney transplants.
Yeah, so kidney transplant is, as its name suggests, you can get a new kidney. The most common source of kidneys is from cadavers, somebody who has passed away but otherwise had healthy kidney function. And then that kidney can be transplanted into someone waiting for a kidney. Unfortunately, there's a long list. There's about 93,000 people waiting for kidneys, and just not enough kidneys for all of them. If someone donates, if a patient is lucky enough to have a family member who's willing to donate, then there's no wait. The wait in New York for a kidney is approximately 5 years. For a family member, if someone is able to donate, then there's no wait. One exciting thing that might be in the pipeline, which we're in the very early stages of, is to get animal transplants. They've placed in a couple of brain-dead patients, and they produced urine. And just recently, in March of this last year, March of 2024, in Boston, I'm not sure, some doctors out of Harvard, I believe, placed a pig kidney in a human. And he came off dialysis and produced urine. Unfortunately, passed away after 2 months. Not clear exactly why, but it's early stages. It's very early stages, but that down the line potentially offers hope for all these people waiting for a transplant, to allow more transplants to be available.
So it's a hard situation.
It's a hard situation, no
and
question about it.
People are always waiting and lists and things of that nature. So if a family member is willing to donate, I know there's all kinds of blood types and different ways to see that whether this would be a good match. Most people now with the medications that we're using can be a good match.
Yeah, to be a match, almost always you can be, and there are all sorts of complicated chains where even if you're not a match for, let's say, your spouse, you could be a match for someone else, and then they have someone who's a match for your spouse. You kind of do a swap. Very common. There have been some complicated swaps involving 12 people. The most important factor is that the donor has to be healthy. Mm-hmm. So if they have diabetes, they're out. If they have blood pressure, it has to be very well controlled and minimal agents. But probably even if it requires one agent, I would imagine that they would be out. So that's the more important limiting factor.
So I want to say thank you to you. It's been a wonderful education about kidney disease. Kidney disease is a very common disease that we have in the United States, and so many of our patients with high blood pressure, so many people even watching us tonight who are on dialysis or are waiting for a kidney transplant. I mean, the ethics, the morality, what goes on with it, as we heard, is just so difficult for family members and other people in the community to watch. And we just hope that everyone stays strong in some of the new things that are going on. And we try to prevent kidney disease by all the things that we described, treating high blood pressure and diabetes. So thank you so much, and we appreciate the education.
Privilege to be here. Thank you.
Have a wonderful night.